Alrighty, so this is Integrated Rehab and Performance Podcast, and today I got Dr. Ben Geierman. Did I nail that one? Crushed it.
Close
Okay,
enough,
fair
yeah.
enough. Doctor of Physical Therapy, Certified Strength Conditioning Specialist, and of course, Barbell Rehab Method Certified. Dr. Ben, thanks for coming on the show. We met at in Murfreesboro during our Barbell Rehab Method certification course, and I'm glad that you found some time in your very busy schedule there on the West Coast to hop on the pod. But today I want to talk a little bit about low back pain. The new stuff that's coming out regarding low back pain, maybe a little biopsychosocial model stuff, the differences between non-specific low back pain diagnosis and the utility of diagnosis versus maybe a more broad diagnosis, things like that, and then just kind of going into the weeds from there. But
Sure. Awesome. Yeah, happy to be here.
Well, tell us a little bit more about kind of your background and how you got into the position where I was meeting you in Murfreesboro.
Yeah. Well, I did my undergrad I'm from Michigan, first of all. I did my undergrad at a school called Grand Valley State University in Grand Rapids / Allendale on the west coast of Michigan. And that was in clinical exercise physiology. Went to PT school at a really small school in Chatham, in Pittsburgh, called Chatham. And so Pittsburgh is kind of where I met Michael, who is our owner of Barbell Rehab. Michael was doing his cash pay physical therapy stuff, and definitely something that I was super interested in. My cousin is a physical therapist. She's, 8 years ahead of me or so. So she was pretty plugged into like the social media world when a lot of folks were starting to post content in like the 2010s or so. So she kind of opened me up to that, thought I'd be interested in it, and I started following a whole bunch of people on there. And it was just following all those folks, consuming all the information I could, and found Michael on there, saw that he was in Pittsburgh, and just kind of slid in his DMs and was, just wanted to see if I could come learn from him a bit. And I got lucky. He responded. He said I could. Shadowed him a couple times. And it was just a little different than I was a tech through undergrad, and was just very used to the classic kinesiopathological model. I was pretty confident with managing pain and treating folks just from how the clinicians I worked under would have me do it when I worked with their patients when I was a tech. Yep. And that whole model made a lot of sense. But as I was following a lot of folks on social media, Greg Lehman, Bronnie Thompson, Mark Cardula, a lot of these folks that have been having some of these conversations, it really started to make me question what I thought, which I think was good because I wasn't super invested yet. I know some people go through their whole kind of education and schooling and maybe 10 years of a career, and then they get maybe a whiff of like some different models or different evidence. And I think once you've dug in and you're a little bit more identified with certain paradigms, it gets a lot harder to change. So I was a little bit I had a little bit of an easier time because I wasn't super invested. I was just really genuinely curious as far as why some things I was hearing were so different than things I was brought up believing about posture and pain and you name it. So Mike was just kind of where I connected with somebody like that in Pittsburgh, and just organically started having some conversations and writing some blogs, and years later now I'm teaching. I'm one of our instructors for our Barbell Rehab Certification Method. I do our podcast, I do our research reviews, and we also have an online course as well for clinical management.
Yeah, very cool. You've taken over a lot of arms of that business there, it seems, and then you practice is it in California itself then?
Yeah, so right now I'm in California. I treated for about 3 years in a chronic pain program. That was one of my big fascinations, and really enjoyed that, but it's definitely a tough population to treat consistently. All your patients coming in with persistent pain, coming in with all these challenges, it can weigh on you a bit. But I decided to try out travel physical therapy. So that's been the last I don't know, it's been almost year and a half, I guess. I was in Portland, Oregon for a bit, and I was in Long Beach, and now I'm in Monterey finishing up. I have a week and a half left, and then I will be starting the new contract, likely in Michigan,
Wow.
be by family again, and go from there.
Yeah, interesting stuff. It brings you all over the world. Do you plan on kind of sticking around Michigan once you get back?
No idea. Yeah, I used to be a big planner.
Sure.
And yeah, the more I've been doing this, all the travelers say you get used to it. But yeah, I mean, you can have a plan, but then there has to be a job, and it has to be a job that has a barbell in the clinic, and it has to be a job that has reasonable patient volume.
Yeah.
So yeah, I'm pretty loose with my locations. I have 4 or 5 state licensees at this
Wow.
stage. So
Yeah. Oh, forget about that
yeah,
part.
we'll see what happens.
Yeah, I see. Well, yeah, interesting background. You had mentioned you were in a kind of a chronic pain type setting for 3 years. We might as well dive in right there, though this can get quite complicated. But when dealing with chronic pain, the idea of having diagnosis that are more kind of pathoanatomical versus maybe playing around in the realm of biopsychosocial and maybe like yellow flag questionnaire type of pain, right? So the subjective part of pain and how you deal with the central elements of pain, right? The brain's interpretation of pain and things like that. What has been like the biggest lesson in those 3 years working in chronic pain? You had kind of been enlightened previously. You had mentioned Lehman and different guys like that. But when you're really putting it into practice and applying it there in a setting like that, what are some of the big ideas that you've taken away from that, and how you thought you were going to be treating patients out of PT school versus how you actually were in a chronic pain type setting?
Yeah, that's a good question. I mean, I got kind of lucky because, in PT school, I always say in PT school I did the minimum effective dose to pass my
Sure.
tests and stay compliant and all that stuff. And on the side, I was just drinking out of a fire hose, reading as many blogs as I could, as many research articles, taking as many courses as I could. So I felt pretty good coming out of school as far as treating fairly similarly to how I treat at this point. Obviously getting more comfortable and getting into more of the weeds, being much further out at this point. But I didn't have to make a super big change there. I mean, if we're comparing kind of classically how I originally, even before I started reading more and getting into different research, I mean, traditionally, if someone has pain, it's just because we haven't found the dysfunction, we haven't found the nociceptive driver, and we just need to find that one root cause. If we find that one root cause, then we can extinguish their symptoms, and easy peasy. And I wanted to be that guy that could do that for people and give them back their life. But I think the biggest thing was just recognizing how realistic is that. We talked about in the course moving away from causes, like a singular cause, more of a unidimensional approach, and more towards all the potential contributors, and just realizing how many factors are playing into this pain experience. Because once again, that's what it is that it's an experience. It's not just the sensation. Nociception is oftentimes there, but then there's a number of other factors that can change the experience and make it a little bit more sour or a little bit less sour based on how those play out. So the chronic pain program was great because even being at different clinics at this point and being surrounded by different coworkers and teaching the course, interact with different individuals, there's a massive spectrum as far as different people's treatment paradigms. And not to say that one's necessarily better than the other. I had Greg Lehman on our podcast kind of talking about this, and the kinesiopathological model, these classical seek and destroy models, these structuralist models can be helpful for a lot of folks. It gives folks an answer, a certainty. In my opinion, it's not an accurate answer or an accurate certainty, but just having that certainty, having that answer, for some folks can be very therapeutic. Now, my critique of that is how does that live, 5, 10, 15 years down the line? But for some individuals, you tell them that, they're breathing wrong, or that certain muscles aren't turned on, or they have, I don't know, you name it, classical fault, and here's how to fix it, they love that. They have something that they can do, and it's more tangible, and that works for some individuals. But for a lot of individuals, especially folks in the chronic pain program, they had went through that whole process and it wasn't successful. So a lot of those folks needed a little bit of a different approach. And it was nice because in the chronic pain program, especially with the main psychologist that I worked with, we were all just speaking the same language. So it's one thing if a patient comes in, they have a whole history of different beliefs, experiences, preconceptions, and then I'm one individual that's telling them, hey, maybe there's something else here. Maybe there's a different way to approach this. Oftentimes, I'm just kind of a drop in the bucket, and I don't have much authority or credibility having some discussions with individuals. But when multiple folks are kind of talking the same language, that's really powerful to help folks come to an understanding of what's helping move them forward, what's not helping, and whether that's the way they're holding their body, different beliefs they have, different habits they have, whatever that is, helping them discover some different opportunities was really helpful, being in a team that spoke the same language versus having a lot of cooks in the kitchen that were all giving different recommendations that were wildly varied.
Yeah. Gotcha. So how does your training, your ability to select exercise and things like that integrate into a model like that? How does an hour with you in a chronic pain setting look different than someone who's maybe more acute? Is it maybe the same stuff, but the language is different?
That's a really good question. Well, so acute for me has looked different over the years. Chronic versus acute doesn't necessarily have to look too different. For me, acute, a lot of it is going through that therapeutic ritual, a good exam, a good thorough exam, making sure that there's no red flags, nothing that makes me think it's going to be a long-term issue. If that's the case, then my goal is to share that good news and talk about treatment options with them. Talk about prognosis, how long I think this is likely to go on, right? That's a big range. Typically, I talk about averages, and then based on what I'm seeing, I'll be honest with them and say, hey, based on what I'm seeing, you're looking really good. I think this is going to be something that you're going to be on that spectrum of somebody who gets better a little bit quicker, or maybe I am seeing more things that are going on that make me think maybe this will be more of a long-term, not a long-term, but something that might take a little bit more time too. So we'll talk about prognosis. We'll talk about treatment options as well. We'll talk about movement practices. I don't need to force feed an exercise on them. That's something I've changed my mind about. Folks don't typically need to exercise to get rid of pain. It's great. It's great for health. I love it. Sure. I endorse it. It's great for function. But from a pain standpoint, there's lots of options, right? We can do a walking program. We can do yoga. We can do Pilates. We can do strength training. There's lots of roads to roam with that. So I try to lay out a buffet of options and then discuss what they prefer. Maybe there's somebody that is looking for manual therapy. I'm happy to do that as long as they understand what is and isn't happening. Sure. So acute is really kind of having that discussion with them and seeing what they are interested in, and really kind of offering guidance through that process. Where I guess the biggest difference with chronic per se or more persistent symptoms is just having the understanding of timelines with that, as far as, hey, this might not be something that has a super promising prognosis. Helping to maybe steer them and assess or kind of a little bit of a vibe check as far as where are they at with what their expectations are. Are they expecting me to be that person that the other 4 clinicians that they've seen haven't been, where I'm going to find the true cause? And really kind of steering them in the direction of how do we kind of manage this over the long run? What are some adaptive strategies that we can potentially use? How are you self-managing right now? Is that helpful? Is that unhelpful? And trying to really make it that partnership as far as, hey, I'm not going to be able to fix you per se. Oftentimes with persistent symptoms, when folks, this comes from Bonnie Thompson's work, she's interviewed folks who identify as living well with chronic pain. It's not necessarily that the pain has gone away. These folks that identify as living well, the pain hasn't necessarily gone away, but they are being themselves again. They're living life on their terms. Obviously, the pain is there, but they are doing things that are meaningful to them, that are valuable for them. So a lot of that is just moving the goalpost as far as, are we trying to extinguish pain, or are we trying to get back to life as soon as possible? And oftentimes by doing that, pain is more likely to change. And what are some strategies that we can help to kind of weather the storm and help you live well with this as time kind of passes by?
Yeah, gotcha. Yeah, it's all about, again, like you had mentioned, moving the goalposts, or just having the correct goals, and the way you talk about those goals. And you had mentioned when you get someone in for maybe initial eval, and you can share the good news with them, and that's part of that kind of language. Same thing with any session you come in. I know patients come in is knowing what things to celebrate, and to just make it crystal clear what is happening when we're getting to certain points, right? We can't just focus on that end goal. We have to have those goals kind of there along the way. We can't miss them. But I want to dive into a little bit when it comes to the way that you're working with patients. When it comes to, again, biopsychosocial, chronic pain versus acute pain, what does a treatment plan for you look like in terms of goals? So we know it's important to have kind of external goals, things that are really important, very specific and precise for the patient itself. But when you're doing maybe an evaluation, what sort of things are you looking for a patient with low back pain? What are like the top 3, 4, 5 things, physical things that you're looking at as things that you want to check off the list and make sure that they're kind of being addressed?
From a physical exam standpoint?
Yeah, that's right. Like physical intervention.
Yeah, that's a good question. So, I mean, there's nothing like uniform that I'm consistently looking for. I mean, I guess just kind of thinking on the spot here, as far as like the elephant in the room would be, I do really appreciate Peter O'Sullivan's kind of cognitive functional therapy approach, where classically individuals are coming in and they're choosing movement strategies that maybe somebody has told them are going to be protective or viable, thinking kind of clenched fist metaphor, where somebody has tweaked their low back acutely, chronically, and they're moving like that metaphorical clenched fist where they're just braced all the time, and they're not letting their low back move at all. So I would say that's something that I'm used to seeing. Short term, I think it's a fine strategy that can be adaptive for some folks. It's not something I necessarily coach folks into, but if they are not doing it and it's not working, I think it's reasonable to use a different strategy temporarily and see if that symptom modifies for them. Chronic symptoms, I see a lot of folks using these strategies, and if I am seeing these strategies, I go through some active range of motion with them, and I just see no reversal of lumbar lordosis. I see them use like maybe a Goward's sign, where they're crawling back up from full flexion back up into extension. They're just not really allowing their back to be loaded at all. That's one thing that usually I flag in my brain as far as is this helpful for them right now. But other than that, objective wise, my biggest concern is just reflexes, strength, and sensation from a neurological standpoint. I want to make sure the neurological system is doing well, and there's nothing that we might need to make a referral out for. As long as that's in line, then my objective assessment is really just getting a baseline of kind of where they're at and what is most limited. And I'm gonna flag those things kind of in my brain, but those are kind of less relevant to me versus kind of their report of what they're seeking help with, right? Maybe they're like, hey, I've had this pain. It is what it is, but I can't garden. Okay, you can't garden. What aspect of gardening is it? Is it that you don't have any lumbar extension? Is it that you don't have any strength to do transfers? That would be components that I'd be more interested in versus like a nebulous, they're missing, a couple of degrees of side bending to the left. Do I need to go after that? Well, maybe if it's relevant to kind of what I'm hearing subjectively from them. But yeah, I mean, so to kind of make that a little bit more concise, I am going through my therapeutic ritual. For me, that is going to be active range of motion. That is going to be hip range of motion, passive hip range of motion, lower extremity strength, sensation reflexes as appropriate. I don't do that on everybody, sure. But based on what they're reporting. And then I am laying them down on prone, doing some PA mobilizations through their spine, pushing through some soft tissues. once again, what am I looking for with that? That's changed over the years. I'm not necessarily looking for hypomobility or things like that. Usually I'm looking for how does their system respond to touch? How does their system respond to pressure? Is there more hyperalgesia, more allodynia? Does this feel good for them, or is it more irritable? Are they kind of clenched and guarded through their whole kind of back region? So those are some things that I'm looking at, but I don't really make strong decisions off of my objective exam, to be honest with you. My objective exam is mostly to satisfy insurance, to make them feel well examined, to make sure I'm not missing red flags. And really my bigger concern is kind of their subjective report, and then very specific things. So honestly, if I wasn't treating an insurance model, I don't know if insurance companies are listening to this, my assessment would just be much more having that conversation as far as what they're most limited with, what they're doing right now to try to tackle that, what they think is going to be best for them, what they think is going on, getting an idea of their activity levels, their goals, and then based on that, I'm going to have a better idea of, okay, what things may be limiting them from a physical standpoint, and then specifically looking at those and going after those things versus right now I do kind of a nice general all-encompassing approach. I think it makes them feel well examined, and that is therapeutic by itself, but B, also to satisfy insurance companies and find classical impairments that they are willing to reimburse us for.
Yeah, has a diagnosis code for.
Yes.
What you had said with this clenched fist, that kind of strategy, that movement strategy. So there's one thing that does kind of transcend, again, whether we're dealing with a chronic pain patient or whatever it might be, there is some physical things that we know we want to look for. And I kind of do the same thing is for, how I refer to it from Richard Olm, who's a DC and a DNS guy. Is, again, they call it kind of that open scissor, extension, compression, stabilizing strategy, another long term for it, all kind of similar stuff, but it's that pattern. You can imagine someone who's been taught growing up to get their chest up and look up and everything's up and just cranking that low back into just as much extension as they can, which is a great short term, maybe not great, but it is an effective short term stabilizing strategy. But long term creates some issues, and it could be better, right? Short term, we could probably improve how we are creating some stability through that abdomen by using the diaphragm and creating other stabilizing strategies where we're actually expanding through the abdominal region there instead of just cranking the erector spinae on this low back muscles to pull everything back into extension, and then you leave the session. And you come back and you do it again and again and again, and over time those paraspinal muscles just stay in that kind of hypertonic state where the back starts aching, not to mention the extra kind of pressure that's being pushed on the vertebrae and the disc through there. So similar thing where that tends to be, in most cases, towards the top of the list of the physical thing. Hey, if we're coming in and we're doing movements, this is something that we want to kind of aim those movements towards. Just getting those paraspinal muscles, reteaching the pattern of stability, which isn't necessarily, transverse abdominis and multifidi, which has kind of come and gone, that transverse abdominis being, the big player, and everything always kind of changes and fluctuates. But I think overall, when you can take a step back, that's where I tend to step to, is just that pattern. Can we trust, flexion of that low back again? Kind of a movement win in your regard with the chronic, patients, where can we get them to do something that involves low back flexion? First of all, can we get that lumbar spine to start flexing again? And then can we get them to do something that they previously didn't think they could without catastrophe? And that's how we get a lot of success, is kind of that goal of just trying to do something, get that movement win. And that's how we kind of go about improving some of those symptoms. And then just improving that overall strategy so that they don't have to rely on that extension compression all the time, or that open scissor, to create what feels to them like their typical stability. Have you noticed, kind of, maybe you can think from your growing up, powerlifting or pseudo powerlifting, right? Just being in the gym all the time and lifting heavy weights and putting stuff on your back. What we're kind of referring to with that extension compression, that's that preference to just get into as much extension as opposed to that other realm of stability where we're not just cranking on that rectus abdominis, but instead using that diaphragm, creating that 360 degree, kind of where things have shifted to a little bit more these days. But can you remember those days of just jamming that low back into as much extension as possible?
Yeah, I mean, classically, like just growing up, reading Men's Health, Muscle and Fitness, like Bro Science magazines, which have some good stuff in there. And so I learned about BFR in that, and like
sure, ahead of the time,
2008 or something. But classically, hey, you never want to go into any lumbar flexion. So I was just in as much extension as possible, because lumbar flexion was how I was going to herniate a disc. So I was always in as much extension as possible. But yeah, probably not the most effective strategy, especially, I look at moving heavy weights as a different conversation necessarily than pain from that standpoint, just because, as we talked about in the course, right, pain, a lot of moving parts, a lot of multifactorial aspects, this dynamic emergent experience, versus moving a heavy barbell. There's going to be more and less efficient ways to do that from a physics standpoint, from a force transfer standpoint. So yeah, when we're coaching folks, heavy deadlifts, heavy squats, we're coaching that stiff, rigid trunk as much as possible. Not necessarily from a injury protection standpoint or a pain protection standpoint, but just from a performance kind of maximizing force transfer for standpoint. Because once again, we put preparation on a pedestal when it comes to kind of injuries and pain. How prepared are your tissues to do this when you are exerting force? If they have a good preparation, you're setting yourself up for success. Shit can still happen, right? There's randomness that is in that system, but that's kind of the thing that we have the most control over from a kind of injury prevention standpoint. Whereas from a pain standpoint, I'm still looking through the lens of, is this adaptive for them? And I'm not putting certain strategies on a pedestal or not. I'm just wondering, hey, is this helpful for you? And if it is, I don't necessarily have a problem with that. But if it's not, okay, let's find some other strategies. And I don't necessarily know what the best strategy is, but we have a number of different options at our disposal. And that's what I want to empower them to kind of explore and kind of find with their body, that, hey, there's lots of options that we have through here. What's productive, what's not productive. Let's move towards what feels most productive for you. Even if there's some arbitrary rule that you've grown up with, that somebody told you of, oh, you can't use this strategy because it's bad. Well, how does it live when you incorporate that strategy? Is it adaptive? Is it more maladaptive? And that's kind of the lens that I'm looking for. And a lot of patients kind of resonate with that. And a lot of times I think that's the biggest thing, just kind of giving them permission that it's okay to explore some of these things. And let's find what works specifically for you. And I might not have that answer, but I'm going to try to guide you through that process so that you can find what's going to be best for you, because it's going to change throughout the years, and I'm not going to be there throughout the years. So I want them to have some confidence to dabble with different movement solutions, different movement strategies, and that kind of thing.
And the key there is that movement variability, right? Just being able to do, or at least pick among a spectrum of ways to move, and not be operating maybe throughout your day in that same strategy, that same positioning. For sure. Movement variability, right? Just the ability to create motion and not be stuck in those same exact patterns. Do you have any issues with people maybe fighting back when you start trying to even implore some of these different changes or just different ways of going about it?
Those are probably all the ones that have fallen off my
Sure.
caseload, and I never hear from them again. There's probably a bit of a selection bias there. Not necessarily. I'm pretty gentle when I bring it up. At least nowadays I am. I'm sure I was less so. I know I was less so when I first started practicing. People would come in the chronic pain program and just tell me that their great toe extension was missing, and that's why their left scalene is breathing instead of the right scalene, and that's why they have TMJ pain. And sometimes I'd be a little bit more blunt than others, but I'm much more gentle at this point as far as really just trying to use that non-judgmental curiosity, more of that Socratic questioning, motivational interviewing, of not telling them the answer, but trying to show them. And once again, I don't oftentimes know the answer, but we are experimenting together. So a lot of it is very much so, hey, would you be willing to try this? What do you notice there? How does that feel for you? and starting to get them to kind of report back to me. And once again, if we're trying something, maybe they are super braced through the spine every time they lift. We play around with maybe some quadruped, really letting the stomach relax, just doing some hips to heels to get some flexion in their back without bracing. Maybe we try that same thing in seated. So now we're relaxed through the stomach, and maybe we're just sliding the hands down the legs and touching the toes and just trying to incorporate that. Hey, how does that feel? Is that okay? Once again, it's a different context. So oftentimes being in a different context maybe kind of might make somebody more willing to use a different strategy compared to standing in the position that they're always used to. And then maybe we're doing some lifting in that position, picking up, a ball off the floor or something. How does that feel? Better, worse, or the same? Is that helpful? Is that unhelpful? And we just kind of explore together through that process, and we see kind of what they lean into as well. So yeah, I like using those movement experiments to kind of show them. But yeah, everyone's a little bit different too. I try to treat comprehensively as far as looking at. We talked about allostatic load in the course, as far as the biggest things that seem to impact health seem to be related to pain as well. So it's kind of a double-edged sword. Sleep, diet, stressors, relationships, just noticing that all these things can play in. So, if I treat comprehensively and I go after some of that allostatic load, or have some conversations and try to guide them and support them in maybe some behavioral change techniques or strategies, and then we play a little bit up with some movement experiments to try to give different options. And then we do a little bit of conditioning as well. We're doing a little bit of a walking program maybe as well. And once again, this isn't something that I'm just throwing a million things at somebody and they come in with pain and now they're leaving with, I have to fix my sleep and my diet and my movement strategies and my conditioning. These are all just different opportunities that they have to maybe move them in a positive direction, and they don't all have to be addressed. But these are all options. And if I lay out more of that buffet option, usually people are pretty selective, because if there's something I'm saying that they just don't like, we don't have to do that. We have other options through here as well. And also, I'm much kinder to myself at this point, as far as realizing that the readiness to change standpoint, not everybody is there. And sometimes they need to see 4 or 5 more practitioners before maybe they're willing to look at things a little bit differently too. So I put less pressure on myself as well if somebody is just a little bit more stuck in kind of where they're at too. Because sometimes people need to go through that process. And once maybe they exhaust, maybe they'll find somebody that tells them a solution that they love, and that of itself will be therapeutic for them. And I'm happy for them to do better with that. Ethically, I can't be that person that lies to them.
Fair enough.
Tells them they just need to hypertrophy their, whatever muscle it is. But yeah, a lot of folks, it's going to take them some time to be willing to look at things a little bit differently, to be willing to go with an approach that maybe is against the classic, just you need to get X muscle stronger, fix your posture, fix this, that, or the other. And that takes time sometimes as well.
Yeah, fair enough. Yeah, I like it. Well, let me ask you a couple things about your treatment, the different things that you've learned over the years, and kind of how you've meshed the interpretation of the biopsychosocial model, central sensitization, things like that, with the physical treatment that you're given, the programming and things like that. Mixing all those things together, what are some must-haves in a low back pain patient in a treatment plan in your regard? Are there certain things from your perspective that you need to have, some certain things that you need to address, not just physical, but in terms of structuring a plan for anybody that's walking in?
Yeah, that's a really good question. One thing I didn't mention, which would have tied into your question as far as goal setting as well, the patient-specific functional scale score. A really nice metric where patients basically just give you 3 things that they're limited with right now. They tell you how limited they are. Maybe they're 20% able to do this. They're 30% able to do this. Whether that's gardening, whether that's picking up their grandkids, whatever it is. Whether it's going through a full training session in the gym, whatever that might look like. So that is a nice tool.
Yep.
To use, because it moves it away from classical, improve range of motion by 5 degrees or this, that, or the other. So I do like to use that. As far as what do I need in a program? I'm a big fan of just addition by subtraction. We know in the research, low back pain has a super promising prognosis outside of red flags. So once again, I want to make sure they don't have red flags. And if they don't have red flags, I want to make sure I'm not doing the things that we know hurt prognosis, right? Early imaging, recommending opioids, giving them narratives that aren't helpful, discouraging movement, encouraging them to miss work, encouraging them to protect their spine, to brace more, to avoid loading. I try not to layer all those things on that we know sludge up the outcome a little bit. And by taking away those things, I'm hoping to put them on a path that's going to improve that prognosis. And again, it's just going to be, hey, we have a lot of options here. So we know that there's no red flags. As far as like, and people talk about this with a lot of musculoskeletal conditions that have good natural histories as far as, oh, well, we shouldn't be like telling them they need to come in the clinic or this or that because it's going to be better in this long or this long. And it's like, okay, sure, like that's fairly reasonable, but those are averages. Not everybody lives on that timeline. Some people take much longer. B, there's a lot of uncertainty through that time. And C, some people just want guidance. I always think about taxes. I could do my own taxes, but it'd take me a while. I'd be wildly confused and uncertain, and I'm willing to pay somebody to do it.
Yeah.
Same thing with a lot of rehab, right? If someone's willing to pay me to guide them through this process, even though they have a good prognosis, I'm happy to do that as well. And that can take away some of the uncertainty, some of the threat, and that may be another thing that kind of reduces sensitivity through their system. So where I'm going with that is a lot of it is educating, hey, you probably have a pretty good prognosis. We probably don't need to be super concerned about this. Maybe they want a diagnosis, maybe they don't. If they do, I'm a big fan of lumbar sprain, strain, sensitized, sunburn analogy, blister analogy, these things that imply more transience than, and we can talk about discs, we can talk about facets, we can talk about nerves. But once again, some people just grasp onto that and it holds them back. So a lot of it, once again, is sharing the good news around prognosis and then talking about the options that we have. That's kind of like more general that I'm doing for most folks. And then from kind of N=1, the individual in front of me, if they do want to go through, however long of treatment that they want, maybe they want to start with, hey, I'd love to come in once a week to get some guidance on this and work on some things. A lot of my treatment is based around their aggravating and their easing factors. So what's most aggravating for you? What are you struggling with doing mostly? What movements, what positions, what activities? And a lot of my approach is more of a graded exposure approach where, okay, do we need to avoid doing some of these things temporarily? Do we need to avoid the sun if you got metaphorically sunburned? Okay, let's find different ways of you to be productive in your daily life and be engaged in your daily life right now while these things simmer. And then as time passes, let's gradually re-expose. So I'm taking those aggravating factors and I'm being mindful of how can we avoid these short term and how can we kind of work backwards from the end product to regress them in a way that they can still do some variation of them to A, make them feel more like themselves, B, to give them confidence that this is okay, and C, to maintain conditioning while we hopefully get back to that. And that, on the other hand, using those easing factors to symptom modify if they need to. There's nothing wrong with symptom modifying for a lot of folks. For some folks in more the persistent pain world, symptom modification is probably not necessarily their friend because if they're constantly chasing symptom modification with a understanding that this is going to be the solution, that may help. That may lead to them getting more stuck per se. Not to say that you can't use symptom modification with those individuals, but I am leaning towards a lot more of an ACT approach, an acceptance commitment therapy approach, where we are trying to move towards their values, be willing to have some discomfort to do those things that are meaningful to them. But zooming out, a lot of it is make sure I'm looking at red flags. Okay, those aren't here. Okay, we likely have a positive prognosis. We have lots of options that we can do. Nothing is necessarily superior. What is your preference with this? I'm happy to vomit my biases on here as far as a walking program and strength training and movement variability. But what does that unique individual want? And then when we are working together and they're in front of me, okay, looking at those aggravating factors, looking at those easing factors, that is going to be my North Star for how we are prescribing movement.
Gotcha. So first and foremost, we need to understand what are the top 3 things that come to their mind that are bothering them, and to what degree. So that can help structure what we're doing and how we do them in our program and in our treatments. And then 2 is understanding what is making things better, what is making things worse, and how can we integrate that into a clinic setting with the things that we're doing there. If it hurts to put your shoes on, then we know that doing things like toe touches or any lumbar flexion movements are in that kind of category where we want to get there, but also we may need to avoid in certain ways. If walking really helps the low back, then we know that extension is probably a little bit better. And we might maybe want to work into more extension type movements when we're progressing pain relieving or any symptom modifying things. So we can take that information and start to structure, like you said, your North Star around what we're doing, but also always making sure that those goals are ending up towards those 3 things they listed beforehand. So yeah, I think that makes a lot of sense to me. Those are, I appreciate that those are essentials in a BEN treatment plan and assessment. So yeah, that's all. It's all great stuff. What you might have touched on it. The last question before we let you go here. What is the biggest low back pain misconception? Can't answer that one.
Man, how do I want to answer this? I don't know what your audience is. I would say probably that it's not normal.
Sure.
A lot of folks come with low back pain. And I mean, I talked about my low back pain experience at the course. That's to nobody's fault. Like, it's not their job to know the data on low back pain. But low back pain is a normal human experience that we likely will all get. If you don't get it, you're probably the weird one. And most of it is non-malignant. It's something that will likely get better as long as we keep living life to the best of our ability, and we don't get that image, we don't over medicalize, we don't create a mountain out of a molehill. So I think the best thing we can do, especially if we are that initial touch point, is to kind of give folks good information that sets them on a positive prognosis. And once again, addition by subtraction. We know all the things that we shouldn't be doing from the research. There's a lot of things that we can do within that. But yeah, low back pain is super common. We call it the common cold or the musculoskeletal condition. Just like the common cold, if you do something for the common cold, it only takes 7 days. If you don't do anything, it takes a week, right? On average, it's around the same time, a week or two, and you're doing pretty well. We know that we shouldn't be giving folks antibiotics for the common cold because now we're just increasing antibiotic resistance, things like that. Maps very nicely on the low back pain as far as we know the things that are making people worse: over imaging, over medicalizing. This, that, or the other. There's a really nice article I just did a review on. Came out a few years ago, but I haven't heard many people talking about it, titled, "Don't Just Do Something, Stand There." How sometimes having that education, having a discussion, talking about the positive prognosis as appropriate with individuals and not jumping into intervening. We have this gravitational pull to just do more and do more and do more, and sometimes less is much better. And by having that discussion, sitting there with patients, answering their questions, answering their concerns. A lot of folks are just concerned of, is this normal? Is this okay? Am I being negligent by not taking care of this? And if you can have that genuine conversation and genuinely reassure them, I think that goes a long way. So yeah, low back pain is super common. It sucks. For some people, it lasts longer than others. For most people, it will get better. And if it does last longer, there's no reason that you can't seek out treatment. But if you're a patient, it's tough out there because there's lots of different narratives, and some are more likely, in my opinion, to set you up for success than others. But yeah, I think a lot of folks really panic when they have that low back pain experience, and we know low back pain reoccurrence is typically the bigger issue because low back pain will likely reoccur, just like the common cold. And if they can have a good experience with a good healthcare practitioner to set them on a positive trajectory and empower them with all the opportunities they have of how they can weather the storm and how they can continue living the life they want to live without changing all these things and quitting all these things they love to do and moving differently all the time and breathing differently, and now they have to be aware of their sleep posture and just putting all these rules on them, that can really empower them to self-manage that second back flare-up, that third, that fourth, and now we're just really equipping them to be less disabled as they do experience the normal ebbs and flows of musculoskeletal pain that happen as a result of being lucky enough to be alive.
Yeah, fair enough. Well said. All right, I think that's definitely good enough to end on. That was a good rant to close us out. Dr. Ben, where can people find you? I guess no one knows. You're all over the place. You'll be in Michigan coming up, but online, you have your Instagram. I'll make sure to put your Instagram stuff in the bio and everything like that. What do you want to tell people about Barbell Rehab and anything else that you're involved in?
Yeah, I always joke with my patients because they ask me the same thing, where I'm going to be next, and I just tell them everywhere and nowhere. My mother also asks often when I'm going to move back to the vicinity, and I genuinely don't know, which makes the answer easier. I don't have to come up with some long tail, but yeah. So best place to reach me is Ben_Barbell Rehab on Instagram. That's where my professional page is. As far as Barbell Rehab goes, barbellrehab.com, you can find out more about us. We have a lot of free resources on there. I do recommend our research reviews to everybody. I am very biased because I write them, but they are completely free, and it's just 2 articles a month. We email out a nice little summary of strength and conditioning research, pain research, musculoskeletal research in general, and I try to keep it actionable for both strength professions, whether you're a coach or a fitness professional, and also rehab professions. So that's something we offer for free. There's some webinars on there we have for free, things like that, the podcast as well. And then we have some courses as well. We have our principles of musculoskeletal management that kind of takes you through how myself and Dr. Miles Nicholas like to treat these different conditions, whether it's low back pain, neck pain, shoulder pain, hip pain, ACL repairs, hip pathology, things like that, and some other courses for both fitness and rehab professionals. And we also do live courses, so we're constantly on the go. I think I'm going to be in New Mexico next at the New Year. And you can find all that online at barbellrehab.com. But feel free to shoot me a message on Instagram if there's any way I can be of help. I met a lot of smart people at this point by, really just bugging them on social media, folks that are putting out a lot of good information and have been kind enough to respond to me. So I'm happy to connect folks to smarter individuals than myself if they have anything that they're stuck on.
Very cool. Excellent, man. Well, appreciate it. Thanks for doing this. We'll do another one sometime soon here. Maybe we'll do shoulder topic or something, but we'll get something.
Awesome. Yeah. Thanks for having me. Great questions. Made me think a little bit. So I always appreciate
that. Man. Yeah. Didn't mean to put you on the spot, but I appreciate you.